Good evening, everybody, and welcome to today's episode of Marvelous Medicine on the journey in search of equity and happiness of the Jan Swasthya Sahyog. As you're all aware, we've had a terrible tragedy happening today, in which even some of our own fraternity and students have probably lost their lives or injured. So, as a mark of our respect as well as our condolences, I request all of you to observe 1 minute silence before we start today's program. Thank you, everybody. Today's speaker is Dr. Raman Kataria. He did his MBBS, MS General Surgery, and MCH Pediatric Surgery from the All India Institute of Medical Sciences, Delhi. He was part of the small group of doctors who came together during their postgraduate studies at the All India Institute of Medical Sciences with the intent to provide high quality, rational, and low cost healthcare to the poorest. They chose to start Jan Swasthya Sahyog at Chhattisgarh. Jan Swasthya Sahyog has been recognized by Jamnalal Bajaj Foundation. It has received the Global Tuberculosis Champions Award, Chhattisgarh Rajya Alankar and Puraskar, and the Bhagwan Mahavir Award for Medicine. I am very thankful to Dr. Ajay Sharma for making this program happen, reaching out to Dr. Kataria and Dr. Kataria for immediately agreeing to do this program. I'm also extremely thankful to the many of the original founders of JSS who have also joined in today. And Dr. Ajay Sharma will be one of the moderators for the session. He's a senior transplant consultant and unit head at Apollo Indraprastha, and also the visiting professor in trauma and transplantation at All India Institute of Medical Sciences, Rishikesh. Dr. Ajay is also All India Institute alumnus, having done his MBBS and MS, after which he went over to the UK. He's a fellow of the Royal College of Surgeons and has also done his MSc in medical education. He conducts the acute critical care provider and instructor courses. He also does the ATLS provider and instructor courses and critical appraisal courses. He has over 195 publications and 7 book chapters to his credit, and he's the founding editor-in-chief of the Journal of World Kidney Academy. A lifelong teacher and a student, Dr. Ajay is currently pursuing his MBA, DBA, and PhD as well. Dr. Piyush Sani will be the other moderator. He's a senior consultant and head of academics at Max Center for Liver Transplant and Biliary Sciences at Max Super Specialty Hospital. He was previously the head of the Department of GI Surgery and Liver Transplantation and the chief of the KL Wig Center for Medical Education and Technology at the All India Institute of Medical Sciences, Delhi. Dr. Piyush is also All India Institute of Medical Sciences alumnus, having done his MBBS, MS General Surgery, and PhD in GI Surgery from there. He is currently the editor of the National Medical Journal of India and is a special section editor of Gastroenterology. The reason Ajay and Dr. Piyush are the moderators are because they have volunteered and spent a lot of time at JSS, and they know Dr. Raman Kataria personally. Over to Dr. Raman.
Yeah.
Thank you. Dr. Ajay wanted to say something prior to this. Would you like to say?
Yeah. The work which has been done or which is being done at JSS is mesmerizing. The most inspiring place to work for me has been Jan Swasthya Sahyog. And I just can't tell you, it is impossible to talk about it in even an hour as to the immense contribution at primary, secondary, and tertiary level care. And way back in 84, when I became intern, I used to be taken to different, slums by Raman Kataria and his and Yogesh Jain, and these two friends of ours, they laid the foundation of this most inspiring institution I've ever seen in my life. So I won't really say much at this stage. I'll let Raman Kataria describe this. And there are many other founding members of this great organization, like Madhvi Bhargav as well as Anurag Bhargav, amazing public health expert. So it will be great to have some comments from them. And Dr. Piyush Sani, Professor Piyush Sani, 4 years senior to me, and it's a real privilege to be a sort of a coordinator or compere of this session. So over to Raman Kataria to really show what JSS, how JSS has been so inspiring. And I must say that acute critical care course, which is to improve and optimize the peri-op care, emanated from JSS. And we know that one very scientific patients have had operations remote place, meager resources, then why not Lucknow, Bombay, and Delhi? We embarked on journey of providing skills in improving perioperative care. And later on, it will be good to have some comments from Shiv Singh, who has visited there as educator.
Thank you, Dr. Ajay, and thank you, Dr. Vidyaman, for giving me this opportunity to talk about Jan Swasthya Sahyog. Uh, uh, thank all the participants here in this meeting who have taken time to come for exploring about Jan Swasthya Sahyog with me. The picture that you see here, the beautiful campus, this is something which has been sort of work in progress over the last 25 years. So we have recently completed our 25 years, and this is a recent picture of this. But I'll show you how it started. And these are the founding members, a picture that was taken almost very early on, probably somewhere around 2002. So you see Dr. B.R. Chatterjee, who's sitting in the center. I mean, the second person sitting is Dr. B.R. Chatterjee. He's a father figure to us, is a nephrologist who trained at multiple places, including at the Johns Hopkins, and then came back to India to work at the leprosy field research unit in Purulia district in a small place in West Bengal. And he spent most of his life doing clinical work and research and service in this district for poor people. So he was, in a way, our leading light, and these are these are the people who started here. I'm standing with the T-shirt, and my wife, Dr. Anju, is holding a baby, which is little Mansi, who's Dr. Yogesh and Rachna's daughter. And then to Dr. B.R. Chatterjee's left is Dr. Bishrup Chatterjee and Madhuri. Dr. Bishrup is a microbiologist also trained with us at the All India Institute, and Dr. Madhuri is a family physician, and Dr. Anurag is to Dr. Bishrup's left, and Dr. Madhuri. Anurag, as everyone knows, is a top-notch medicine expert and a public health expert, and Dr. Madhuri is also a public health expert and a researcher. And Dr. Yogesh Jain to his left, who's a pediatrician and a public health person, and Dr. Rachna, who's a gynecologist. So this was the initial team, and we were fortunate to have Dr. Pramod Upadhyay, who's a senior scientist at the National Institute of Immunology, and he was part of the team in trying to start the appropriate technology work at Jan Swasthya Sahyog. And then Dr. Satyamala, who was again a public health person who was senior to us and already had experience. She was from the CMC Ludhiana, and then subsequently she did public health work at several places, and so her experience actually immensely contributed to starting the community health work at Jan Swasthya Sahyog. So thank you to the entire team, many of whom are here today. So the society, or the People's Health Support Group Jan Swasthya Sahyog, was founded in 1996, but we actually started work on the ground in Chhattisgarh in the year 2000 with the goal of equity in healthcare, working in this rural tribal belt since the year 2000. And for those of you who are not familiar with Chhattisgarh, this is the seahorse-shaped state that was carved out of erstwhile Madhya Pradesh. And the terrain that one encountered in this area, which was a forested area, Chhattisgarh has a large forest area. And the area that we chose for our community health program was a forest area, forest and forest fringe villages. So it was crisscrossed by seasonal rivers, and hamlets were far apart. And this you can see a Google map of the area where we are working. It's divided into 4 clusters. Manual labor is very important and is the main source of income for the livelihood for people. And poverty is rampant. Premature deaths when we came were fairly common in this area. So we aim to provide low cost and yet high quality healthcare for rural poor, primary and secondary levels, and if necessary tertiary care, all of it seamlessly for the people. So what stood out was the hunger status or the undernutrition of people, which often was overlooked because BMIs of 15 and 16 were fairly common when one started working, even amongst people who were not patients but only accompanying patients. And then even in the community, these BMIs were fairly common. And if you look at these BMIs in the population, you find that women had median BMIs of 18.5, while men had median BMIs of 19.1. And there was a clear pecking order with the particularly vulnerable tribal groups or the primitive tribes faring the worst, followed by the regular tribes, then the backward caste, the Dalits, and then the others. So the premises and the strategies were that healthcare is the right of the people, and on grounds of equity to ensure primary healthcare seamlessly and comprehensively, while building a collective conscientization and learning from the problems that one faced day to day. Also using force multipliers of training, research, and advocacy, because many of the problems did require a significant effort. The values that we cherished and we tried to follow were honesty, integrity, the respect for the poor, the village folk, an understanding of their problems and an unfailing commitment to them, and compassion and respect for the wholeness of human beings. So very early on, we realized that even in these beautiful green surroundings, forested surroundings, problems were not small. For example, this baby who developed a post-burn contracture because fell into the fire, the elder sib who was holding this baby had uncontrolled epilepsy. And this is what led to this bad contracture, or this newborn intestinal obstruction, or this woman who had a burn on her back which never got treated or healed completely and several years later turned into a malignancy, a Morgellons ulcer. Even a child with a Morgellons ulcer, which was very advanced, is in the other picture, seen in the other picture. All these 3 children at the same time had something which could easily have been treated with appropriate and early treatment of their pneumonias, but they ultimately led to it developed pus in their thoracic cavities and empyemas, which required major procedures. This patient with diabetes who presented for the first time insulin-dependent diabetes with blindness, he was severely undernourished and was unable to stand, had developed contractures because he had been in bed for a very long time. And this is this patient after receiving treatment when he came for his first follow-up visit. Snake bites, which are fairly commonly seen in this area. So, illnesses we realized are embodiments of deprivation, and that the burden of ill health is disproportionately high among the poor. They are more complex illnesses with delayed presentations coupled with undernutrition and a lack of access to quality care, requiring the treating physicians to be better trained and skilled both clinically and socially, as well as to be multi-competent. And these were the principles that underpinned the effort: comprehensiveness, community basing, while still respecting the individual, equity, responsiveness and support, and the quality of training that we provided. And this was the 3-tier model of care, that the way that it was provided. The first tier being at the village level with 144 village health workers who were trained from within the same hamlets in the forest and forest fringe villages. They were trained over a period And then subsequently, they have been handled even to this day. That means 25 years on, they are still handled. They still have refresher trainings every month. And then the sub-center was at the tier 2, which were in clusters of these villages. And then the referral center, which was the base hospital in the village Ganyari. Ganyari was incidentally an old irrigation colony, which was given to us on lease by the government, and which we developed into a hospital come a training center subsequently. So the village health program provides care through the village health workers, the 144, the senior health workers who are the mid-level care providers who have been stationed at the sub-centers or the health and wellness centers as they are now called, and the nurses at these sub-center clinics and the home visits that they do. Non-communicable diseases including patient support group meetings, maternal and child health, malaria, acute febrile illnesses. So all of these are treated, and then the Pulwari program to take care of the young child malnutrition and provide early child education. Almost 1,800 children are enrolled for this Pulwari program. These are some pictures of the community health program work going on at the sub-centers as well as at the community level. Community-based palliative care, which is a more recent intervention. The doctor as well as trained nurses who have been visiting patients with malignancies, who have advanced malignancies at their homes. So just to give you a glimpse of what comprehensive care in our community means is this example of a lady, Meera Bega, who was hailing from a remote hamlet in Banni in the forest, started developing extreme breathlessness almost early in the morning, very early in the wee hours of the morning. And Jivanti Didi, a health worker who was staying nearby in the same hamlet, she suspected it to be due to a snake bite, which are not infrequent in these villages. So poor roads and absent public transport, the raging monsoons at that time, they made travel extremely difficult. The rivers were flowing. So the village community gathered to help her across the flowing river to reach the JSS Banni sub-center. And upon reaching here, our senior health workers, who were already informed about her problem, they administered the anti-snake venom and prepared her for a referral to the base hospital in Ganyari without delay. After crossing another full river, she made it to a waiting ambulance of JSS where the doctor took charge, because the doctor was also there in that ambulance. And she was put on a tight mask and bagged for the next 40 to 45 minutes of her journey. And then when she reached the hospital, she was there in the ICU. She was ventilated for the next 5 days and she became well enough to be discharged. Such stories usually, they are fortunate, but sometimes it can be a touch and go situation. And we recently lost one patient of a similar type about a week ago. So vital statistics in the intensive program area, this is how it has evolved over the last 2 decades. I was talking about the referral center at Ganyari, and the picture below shows the dilapidated buildings of the old irrigation colony, which were converted to this hospital gradually over a period of several years, brick by brick. So these are the services that are provided at the referral center with the team of 12 consultants, 2 senior residents, 10 DNB residents in both general surgery and family medicine, visiting faculty and specialists, volunteers and interns, nursing staff and nursing interns, lab and blood storage unit staff, the pharmacy staff, and certain non-clinical staff. And the services provided are outpatient, 150-bed IPD services, surgical, obstetric, HDU, emergency, a low-cost, rational and generic pharmacy, a diagnostic laboratory which is able to provide several investigations in-house, imaging, both X-ray and ultrasound which are available in-house, and telemedicine and mobile clinics at the subcenter. And the broad specialities besides medicine, surgery, pediatrics and OB-GYN, we are able to provide ID, infectious diseases, oncology, pediatric surgery in-house, all of these. And then several which are used, which we are providing through teleconsultations, nephrology, neurology, cardiology, rheumatology, psychiatry, endocrinology, and Ayurveda, which is also provided in-house. We see nearly 400 new patients in a day. 3 to 5 days waiting period is quite common. 400,000 patients have been registered till date with over 800,000 consultations provided. 1.5 million population accesses these from 9 districts, both in Chhattisgarh and eastern Madhya Pradesh, from nearly 2,500 villages. And nearly 38,000 surgeries have been performed to date. Just to give you a glimpse of the burden of illnesses in the previous year, tuberculosis, we saw 448 new cases last year, 760 cancers, which was a significant rise from the previous year. Severe hypertensives, 510, diabetics, 864, most of whom were lean diabetics. Illnesses requiring major surgery, over 1,700, sickle cell disease, 79, leprosy, 75, and rheumatic heart disease, 56. So we see nearly 5,500 inpatients annually. And what is important is not just clinical care, but also social care, caring with empathy and dignity, respecting their cultural practices that are not harmful, and being in dialogue with the patients and their guardians, understanding their situation and needs when in the hospital, and being responsive to them. The view of the laboratory, the wards, TB, one of the major illnesses that we see, 531 new patients that we saw, 51% were pulmonary TB and 46% were extrapulmonary. 3% had both. The comorbidities most commonly seen were diabetes in 24 and HIV in 6. And of course, very severe undernutrition was also very common. And 18 out of the 21 TB deaths had BMIs of less than 14. Surgical services, we saw we did more than 2,500 surgeries, out of which 80% are major surgeries, and children form nearly 15% of the operated patients in the pediatric surgeon. We have recently started doing ophthalmic surgery and also have recently started orthopedic and ENT surgical services. The JSS experience in cancer care the last year showed a total number of 760 patients. As I said, it was a significant increase over the previous years. And 678 patients were managed. 389 received curative intent. 289 received only palliative care. Patients were managed with chemosurgery and palliative care, 678. And 185 were referred to for radiotherapy, which was arranged at 2 hospitals where it is provided through the Ayushman card in Raipur. Oral cancers top the list with 32% of all malignancies, and breast and cervical cancer are fairly close, and then followed by gastric, ovarian, and other malignancies. Teleconsultation, which I talked about, there is no limit to getting expert help provided the person at the other end who's giving this consultation is tuned into the ground realities in this place. And this we can see here, for example, Dr. Prashant Gogia, who's a psychiatrist, giving this consultation, sitting in Germany because he has visited JSS several times and he knows the context. So low-cost care, how did we manage this care? There were several things that we decided to do early on. One was that time was extremely precious for people, so we decided to follow the one-day principle. So anyone who came to the OPD, we tried to do the initial consultation, their investigations, and then the follow-up consultation with the doctor, their prescription, and the drug dispensation. Everything was done on the same day. So the patient went back, getting their entire treatment on the same day. We tried to use several alternative management algorithms because several high-end investigations are not easily available. Early nutritional support and mobilization, reducing hospital stay as far as possible. Training local manpower, that is extremely important. So we developed teams which have a significant component of locally trained manpower, both in the community as well as in the hospital. Multi-skilling was also important, and linkages with other institutions because we did not have all the specialties with us and all the facilities with us. And regional anesthesia where feasible, and reusing and recycling because it is important to reduce the cost. We used ETO. Reducing the cost of drugs and diagnostics, we've been using from the very beginning, thanks to Dr. Anurag, good quality generic medicines at negotiated rates. The pharmacy has only generic medicines. an in-house laboratory for most investigations, and institutional tie-ups for investigations. And the financing that we use is using government-supported programs like the Ayushman Bharat PMJAY and providing credits and discounts where appropriate when patients are not able to pay. No one is denied care irrespective of their paying capacity. And we refer only if it is unavoidable with a specific purpose and after discussion with the referring physician. So no unnecessary referrals are made. We try that patients get their entitlements as far as possible. A decade back, we could raise 1/7 of the organizational budget through patient collection. Today, thanks to the scheme, we are able to raise 1/3 of it, out of which 3/4 are supported by the Ayushman Bharat, despite its challenges. We need to consider applying alternative mechanisms swiftly when digital technology fails, because it often fails for the most marginalized. For example, the elderly, those who are on chemotherapy, their fingerprints don't work, those who have been on migration and their papers were never made. So these are the poorest and the most marginalized who actually face these problems with digital technology. The allied programs with which JSS is involved is health system strengthening with the government, trainings, appropriate technology, research and publications, agriculture and animal health, and advocacy. And I'll briefly just touch upon these. The health system strengthening work has been going on for the last 8 years now, and most of it is focused in eastern Madhya Pradesh. We started with 6 districts, but now we have come down to 2 districts, focusing entirely on these 2 districts of Anuppur and Dindori, where the work that we do is related to quality improvement of maternal and neonatal health services in collaboration with the state at the CHC and the district hospitals. And the Pushprajgarh Health and Nutrition Initiative. Pushprajgarh is one of the most backward blocks in Anuppur district. So this initiative was started, addresses nutrition and health issues in collaboration with the district administration at 12 sub-centers and 75 Pulwadis that are being run there. We started the sickle cell program in Madhya Pradesh in the year 2018 for the diagnosis and management of sickle cell disease. We have covered over 2.4 lakh population. It was a population screening, and 2,900 patients with sickle cell disease have been diagnosed, with over 28,000 sickle cell trait patients through a population level screening. And starting with pregnant women, family members of sickle cell disease patients, adolescents, and children. But not only did we screen and diagnose, but we also ensured that they were managed through public health facilities, and we also grouped them into patient support groups. And now we are able to have patient support groups as large as 50 to 70 at the community health centers and 20 to 25 at the health and wellness centers. So fairly large patient support groups of sickle cell disease patients are there. Appropriate technology work has been done right from the very beginning, because we felt that healthcare needs to be accessible, and it needs to be made cheaper and simpler to use, and it needs to be demystified while it still remains accurate and efficient. So these are some of the skills, aids, and techniques that we have used or developed. The H2S bottle is used for testing the quality of water, whether the water is potable or fit to drink. And once it is put into this filter paper based test bottle, then the water, if it remains translucent, it means that it is fit for drinking. But if it turns black because of H2S producing organisms, which are the coliforms, fecal coliforms, it will turn black, and that means that the water is unfit for drinking. It needs to be incubated at body temperature for 24 hours, which can be done against the skin. So it's a test which is available at the village level to test any source of water that one is using. And if it is unfit to drink, then there is an ultraviolet based water purification that we have developed, where for 15 minutes, if this water is treated with ultraviolet light, it becomes fit for drinking, and we have seen that. And where there is no electricity in several of our villages, there is no electricity, so it can be used using a bicycle dynamo, and just pedaling a static bicycle and a bicycle dynamo is able to treat this water. A hand wash station. There are several technologies which we developed for the health workers. A teaching stethoscope, which had 2 pairs of earpieces and 1 chest piece, so that the teacher and the taught hear the same thing. a breath counter for detecting newborn or infant pneumonias, infantometer, a newborn sleeping bag with a heat source which can be used in the community. So this can keep a baby in a forest villages which are fairly cold at night, especially in winters, can keep a baby warm. Even a preterm baby can be kept warm, low birth weight or preterm baby can be kept warm for almost 8 hours through the night. A nylon mesh, which is commonly used for mosquito netting, the same mesh, if it is autoclaved or ETO sterilized, it can be used even for uh, treatment of hernias, large hernias. Hemoglobin electrophoresis, we developed this low-cost hemoglobin electrophoresis because the test was fairly expensive. What it cost in the market was somewhere close to 500 to 600 rupees per test, or if we bought the apparatus, it was more than 2 lakhs. So we made this apparatus which cost about 12,000 rupees, and per test cost came down to 20 to 25 rupees. So, and this is equally reliable and accurate, and it is something which can be mended if there is a problem at the same place. An accurate tele-ECG on mobile phone, which was developed by one of our colleagues, Dr. Rajneesh Juneja, who unfortunately is no more. And this can transmit the ECG. It's a very small portable device, but it can transmit the ECG from the community over a phone, a mobile phone, to a clinician. These are some of the appropriate technologies in the pipeline. Successfully tested an in-ambulance oxygen concentrator, also a UV-based water filter for tap water, developed low-cost biogas plant, field testing is going on, and a low-cost insulin fridge for rural areas because refrigerating insulin in rural areas is a big problem. We can also call this appropriate technology where age-appropriate food is not available easily, and there's no one to feed these children when they are at home, especially those who are between 6 months to 6 years. That 3 years, when the mother goes after weaning the child, she goes for work, and this is the time that they usually fall into the undernutrition trap, and then continue to remain stunted and undernourished. So our kulwaris provide 70% of the caloric requirement and almost 100% of the proteins in the 8 hours that the children are kept in the kulwaris. And they are also taught games, and in a play way, they learn how to negotiate the world. And therapeutic nutrition, this is a WHO formula using peanut, milk powder, sugar, and oil, which is ground and mixed as a paste. And no water is added to this so that it has a shelf life of about 3 months. Provides 560 calories and 18 grams class 1 protein, and is extremely palatable. So this is used for patients who are severely undernourished, who come for surgery, or who have any illness who visit us. These are e-patient records. We developed our own electronic medical records, courtesy ThoughtWorks Incorporation. So they did it pro bono for us, but they picked on our brains to see exactly what is required for a rural hospital and how this can be made most convenient paperless system for the hospital. We have also used Avni Field Service and data collection platform. Again, this has been mostly developed in collaboration with a software group. So we have worked extensively now, more recently, on the social determinants of health, agriculture, animal health, and self-help groups of women. The agriculture program actually started in 2003 with the system of rice intensification technique because rice was the major crop. But subsequently, we have used this same method for wheat and for ragi as well. More than 400 traditional varieties, the hardy varieties of rice, have been preserved. 16 varieties of wheat and 6 varieties of ragi have been preserved. Villagers and women from self-help groups are also involved in this process. The animal health program, over 4,500 animals are treated in the community annually, and we have a full-time veterinary doctor. And on the lines of the village health workers, we also have animal health workers in the villages. And we have self-help groups, and there are over 100 self-help groups, with 47 of them doing good financial activity, a livelihood activity. Training and support to farmers through monthly village meetings on natural farming practices like the use of Jivamrit, green manure, no use of chemicals, use of local seeds and seed treatment, and encouraging the production of millets. We have also installed in the community in these villages a millet processing unit, an oil extraction machine, a biscuit making unit using ragi and jawar. So these are some of the things which we have done very recently in the last 3-4 years. We have launched in 2023, we launched this platform Garima towards a sustainable Swaraj, which is Gramin Atmanirbhar Rajgari Manch, with a vision of sustainable development uh, for farmers to have a self-sustainable model through collective ownership of organic farming, free of chemicals and locally processed by our self-help groups. We have been advocating on several issues very early on drug pricing and procurement, which still to date has been continued by Dr. Anurag. Diagnosis and treatment for tuberculosis patients. Again, Anurag has worked extensively on this. Antiretroviral therapy availability for HIV patients, food availability through the public distribution system, the diversity in the food that should be available through the public distribution system. We've talked about this. Diagnosis, treatment and control of malaria, early child nutrition through Kulbaris, radiotherapy and cancer treatment, universal health care, village health worker and mid-level care provider for rural health care, some of which have been incorporated in the Mitanin program and subsequently the ASHA program of the government, and also the mid-level care provider, which are the CHOs at the health and wellness centers. Several research works and publications have been done. One of the major ones was to understand the burden of various illnesses affecting the rural poor, to affect best practices, and to bring awareness and change at the policy level. Trainings are an integral part of the work that we do, starting with training of local manpower, both informal as well as formal courses, building local capacity, and people so that people are much better tuned into the realities of the local people. We started the JSS nursing school in the year 2010 with the ANM program, which is a 2-year program, and subsequently upgraded it to the GNM program 4 years later. This is a 3-year program with 25 students being taken every year. And we now have to shift to the BSc nursing program. The academic components include a significant community posting and community research. Most of this nursing program has been funded by the Tribal Welfare Department of the Government of India. Specifically, therefore, it has been for female students belonging to the marginalized communities, the SC and ST. We have also recently started paramedical courses in the operation theatre and pathology technician courses. These are some of the students, and you can see Sister Kutti, who's taking a bedside class. She's one of our senior nurses working here for almost 18 years, and both the nursing in charge at the hospital level as well as looking after the training at the nursing school. We have postgraduate training in general surgery, trying to groom true surgical generalists who can provide the critical access to surgery that is needed in rural areas across a wide range of subspecialties and resource-constrained settings with compassion and with dignity. These residents are not only taught about the surgical and clinical skills, but also about the intersection of illness and poverty. We have a postgraduate training program in family medicine. Again, they are specialist generalists, ideally trained to provide preventive and curative services in rural areas. I'll just briefly go over the challenging and interesting problems in the surgical field, as I'm a surgeon. So I thought that it would be interesting for you to know about the type of surgeries or surgical problems that we deal with. Surgery has been a neglected stepchild of public health. No one talks about surgical care as part of public health. And children's surgical needs are nowhere on the horizon. But a surgeon, especially a trained child surgeon, can really help both children and adults in a wide variety of specialties, as I have seen. And my clinical role has been that of a true general surgeon. So beginning with newborn problems, this is an intestinal obstruction, a rare type, where the entire small bowel, after having undergone intrauterine volvulus, there was necrotic small bowel that was present in the abdomen, and it had led to an atresia at one end and meconium-filled bowel at the other end. And we were able to manage this operatively, and this is the child playing when he had come for his stoma closure. This is a rare problem which I encountered for the first time, hypothyroidism in the neonatal period, presenting with rectal prolapse. So this baby, I had not seen such a problem, and I consulted my pediatric surgical colleagues at AIIMS, and I was told that this is a rare problem, and the treatment for this is simply doing a colostomy by pulling out pulling up the prolapsed rectum into the abdomen and then fixing it using a colostomy. And we did this and the medical management with Eltroxin, and the child has been doing well. We have been able to reverse the stoma also. A choledochal cyst presenting in such an advanced stage, 2.5-year-old female child weighing only 9.5 kg. I will not go into the details, but this was a tough problem, especially considering the severe undernutrition. But the child ultimately did well. Another choledochal cyst in an 11-year-old girl who presented with abdominal pain. Parenteral nutritional support is actually required for several of these patients. And if one looks at the Ayushman Bharat PMJAY packages, TPN is nowhere on the horizon in that. So this is something which one has to provide for several patients who require urgent surgical intervention, but at the same time require nutritional support. Hydrocephalus, meningomyelocele, childhood malignancies, and again we have tried to coordinate with other institutions, specifically AIIMS Delhi, where hepatoblastomas we have been able to diagnose and then start them on chemotherapy neoadjuvant, and then subsequently when they required liver resections, major hepatic resections, they have been able to undergo that at AIIMS Delhi. And this is one such patient, the girl on the right, who's standing with her father. She is now married. She is now 21 years old and married. So this is one of the patients of hepatoblastoma who came to us early on. Sacrococcygeal keratomas. So again, a late presentation with severe undernutrition with obstruction in a patient with GI tuberculosis. Pediatric genitourinary problems, a rare problem which we saw 4 patients in a row over the last 3 years of MRKH partial. That's Mayer-Rokitansky Kuster-Hauser syndrome, where vaginal substitution was done using a pedicled sigmoid segment. This is the other one is a flap urethroplasty, a buccal mucosal flap urethroplasty, or an onlay flap urethroplasty here. And this is persistent Mullerian duct syndrome, where subtotal hysterectomy with bilateral orthodexy was done. Augmentation gastrocystoplasty was done for extrophy bladder. A strange airway foreign body. This is an LED bulb which this child had aspirated by mistake from a toy 3 weeks before he presented to us. He had already been to 4 hospitals, both in the public and private sector, in 200-kilometer radius. 3 of them had attempted bronchoscopic removal unsuccessfully, and this child was still roaming around with the foreign body. We did one more attempt at bronchoscopy, but we found that the bulb was too far and was in a position that it was not possible to remove it with a grasping forceps. So we did an open thoracotomy and a bronchotomy, removed the foreign body, and the child as well. An ulnar osteoclastoma, where we did a free fibular graft after resection of the tumor. Oral cancers, where we have done difficult reconstructions, again with the help of plastic and microvascular surgeons, whose help we have been able to enlist more recently. Otherwise, these patients would have been declared as non-operable because it was not possible to reconstruct them. Prefibular flaps. again, some of the others. We saw a patient with papillary, a young patient, 18-year-old with papillary thyroid carcinoma and SPEN, both occurring at the same time. So two malignancies in the same patient. We had not seen something like this. A pancreatic head carcinoma, which we had not thought that we will be able to manage. Uh, we were able to give her neoadjuvant chemotherapy and ultimately were able to operate on her after CBD stenting and once her bilirubin improved, neoadjuvant chemotherapy was given, bilirubin dropped to 1.6 and then we were able to do a pancreatic duodenectomy. Port spine, again with extensive lung involvement as you can see on the MRI image. Fixation has been done in this patient. TB in this 18-year-old girl, a true consumption, presented with features of intestinal obstruction, tender abdomen with fever, imaging was suggestive of obstruction. It was extensively inflamed gut with no planes, multiple bowel perforations were there. We put in drains and we had very little hope for her, started on antitubercular treatment and TPN. She stayed with us for nearly 2.5 months and from a BMI of 12, she gained 14 kgs in the next 4 months. So what was key was the morale that we kept up. And this is one of our residents, Dr. Deepak, who encouraged the mother and the daughter throughout her hospital stay. Bilateral lung hydatids, we didn't know that they could become life-threatening when we started them, especially when we started them on albendazole therapy. So we asked this lady to stay in the hospital, close to the hospital. And she presented 4 days after starting albendazole with respiratory distress and hypoxia to the emergency room, where she was taken up for surgery and then both sides had to be operated. Severe post-burn contractures, oral submucous fibrosis with almost complete trismus, severe contractures with tissue loss. So these are patients who would otherwise, poor patients who would otherwise be destitute because they require a collaboration between departments, orthopedics, plastic surgery. So various departments need to collaborate in several of these cases, and we have seen that they drop very soon because they don't get the care that is required. Difficult urethral strictures. This is buccal mucosal graph, and that's an end-to-end anastomosis, the other one on the right. So these are some of the lessons that I learned during my work here, that we are amongst the very few lucky who have become doctors and then learned the art and science of healing. So it's not, I don't want to sound preachy, but at the same time, I think it's important that our interactions not be transactional, but humane and empathetic. We must pause to ask a set of poor parents about what it took them to make this journey to our hospital, what they have already spent on treatment, and factor in their time and earnings lost as well as their indirect expenses. Medical impoverishment is amongst the top reasons for people on the brink falling into the poverty trap. And each action of ours is important, using good clinical skills, minimum rational investigations, rational and timely treatment, and good explanations at each stage because there's often a huge information asymmetry. So we often hear about high quality care, and it is sometimes mistaken for the latest cutting edge technology. I have seen this happen at my own institute in AIMS, in my own department, in pediatric surgery department. The proven best, evidence-based is of course desirable, but in our society with humongous economic disparity and disparity in physical access to healthcare, it is worthwhile to remember that the best need not be the enemy of the good. And it is also true when we are called in as experts to set guidelines that we must rooted in this reality. Whichever setting we are capable of providing relief and often cure within our limited means if we strive hard enough. And finally, it is useful to measure outcomes, but it is also useful to see meaning in what we are doing, of whichever illnesses or anomalies one is treating. Think of the innumerable barriers to accessing healthcare in tertiary setup and hence the persons who did not make this journey to us. How can we help improve this access? training doctors at the secondary level, district and sub-district hospitals to identify and refer such problems early, using government schemes and patient entitlements like the PMJY, free drugs and other state schemes to help, reducing waiting times and lab visits to the minimum, rational investigations and prescriptions within our hospital, and getting involved in helping to make this happen, and of course, providing the best possible care in our settings. So all this is a vital part of the quality of care with equity. And I thank you for your time and gratefully acknowledge the village folks and our patients, our health workers, the entire JSS team of more than 800 people, executive committee of Jan Swasthya Sahyog, which has been guiding the work of JSS, and financial support and several times moral support also from several of these partners, Tata Trusts, the Friends of JSS in UK, in Germany, and in the US, the Association for India's Development, the Azim Premji Foundation, the MacArthur Foundation, NOVID, and several CSRs, friends and well-wishers, and the support for patient care and research from the All India Institute, from CMC Vellore, from the Azim Premji University, and several individuals in India and Russia. I thank you all. I'm grateful to you all. Thank you very much.
Thank you so much, Dr. Raman. Thank you so much, Dr. for taking us through this journey. Over to the moderators, Dr. Ajay and Dr. Piyush.
Yeah,
can
I
just
would
stop
request
sharing your
Professor
screen.
Piyush
Just stop sharing your screen.
I request Professor Piyush to lead the question answer session, the comments.
Thank you, Raman, for agreeing to do this. I wish there was a way of getting this across to a much, much larger audience. Before I say anything else, I would like to ask Anurag, who was there at the time everything started, and Madhavi. I unfortunately, when I visited JSS, both of them had left by that time. I request them to say a few words before we take questions from people. Anurag, would you like to start off? I'm not sure if I can see anyone of the other founders on the part of the founding team on the group. But if anybody else can see anyone, please do let me know, and we'll request them as well to speak. Anurag, you're muted.
I think Madhavi, who was sorry. I would ask Madhavi to go first and with some comments.
So when I look back, I realized that I entered JSS as a very impressionable young person who was very fortunate to have the best two pediatricians, Raman and Anju, and Yogesh and Anju, and a pediatric surgeon who was a general surgeon, and Madhuri, who was a wonderful generalist. Anurag, of course, was my teacher before before we got married, and Vishwarup, who taught us the importance of lab. So I cannot imagine a young doctor who can be exposed to some of the best mentors, and those 10 years have shaped my life, I can say that. And they all turned me into a professional mutant basically. So I started with slides of tuberculosis and leprosy. Raman taught me the ropes of surgery. So I never practiced ENT surgery, but of course Raman, mentored me into doing everything, including prostatectomy, where I remember an anesthetist asking me whether you have to remove it from above or from below. So I stopped here, but I am what I am because of all these wonderful people. Thank you.
Well, I'll just keep it brief because my mind is in a spin with seeing all the work that has emerged. So just for the sake of people, we were there from 1999 to 2009 November. So I did work for 10 years in the formative phase of JSS, and very happy to see that in that 10 years, we had really covered a lot of the ground also, for which foundations this has been, it has really flowered. But I would say that I was trained in AIMS, but a lot of the learning really and unlearning happened in JSS. So I am a MD from AIMS, MSc Epidemiology from McGill, but a PhD from the University of Rural India, which that PhD is not recognized still, but it is the most valuable degree that you can have. I would just say that the JSS experience shows that if a group of people with persistence and commitment work there, it is probably the most fulfilling experience you can have in your life. Of course, it was very, very challenging, but I must say that whatever we experienced there was a huge disconnect between what we were taught in AIMS or what we were taught in medical colleges and what we are seeing there. And we have been, in that sense, completely disconnected from the ground reality in India. We are not only physically distant from the mass of people in India that we are serving, there is also a social distance. We do not, there is no sense really that these are also fellow citizens of our country. And I think that is one of the driving reasons why persistent inequalities of the type that Raman has shown. This cannot be consistent with a country which is now supposedly going into a developed phase, because this is inequality in an extreme ways. And in India, still there are medical deserts and surgical deserts which need these kind of initiatives. So I would say that the healthcare thing which JSS taught me interesting was primary care is where we should focus our efforts, and comprehensive primary care is the way not only of treating diseases but to improving health in the overall term, which we can see in the JSS experiment. And the social determinants of health that we are talking about, poverty, undernutrition, poor access to care, poor quality of service, and behavior. Many doctors say, what can we do about it? But it is not enough. At least we can be sensitive to these issues when we are seeing patients, and at least we can do no harm. The amount of drugs or prescriptions or this thing we are actually doing harm. So those are my comments, and I would applaud Raman, Yogesh. Bishrup is not here because of certain logistical reasons. It was really a very, very this thing. And as Madhvi says, we have just continued working on the same issues that we saw in JSS and given some shape to them. Thank you very much.
Professor Pishtani, Yogesh Jain is also on this platform today attending, and also we'll have some comments from Dr.
If Madhuri or Bishrup are here, then they could.
We'll have comment
from. If you're there, could you say a few words?
I'm not sure whether he is muted or. In the meantime, while Yogesh is coming up to speak, maybe we'll have some comment. Hand is raised by Dr. Shri Vidya Venkat Raman. You would like to say while...
I am from Chennai, and I really identify myself with the work JSS is doing, because I am an alumni of MJIMS Sevagram. And that is one of the premier rural medical college, and I did my MBBS and MD both. I did my MD internal medicine over there, and amazing, because we had to do a mandatory 2 years rural service, one of a kind, which I did for 1 year in Gadchiroli, unheard of in those days, around 24, 25, almost 30 years back, and full Naxalite ridden. And I can absolutely identify what MP is still there right now, and really, really amazing. Believe me, I actually am feeling very ashamed that after coming from such a prestigious background, I am stuck in a corporate jungle in Chennai, and I'm really looking forward to my retirement to go back to the rural roots. I really, really thank you very much, Vidya, for doing this particular session, because I really realized that there is so much of disparity between the urban and the rural India even today. We are so developed in so many ways, but we are still underdeveloped when it comes to health sector. Thank you very much. Yes.
Could be a comment from Dr. Deepak Chandra Badani, who, after having worked in JSS for quite some time and having led lots of journal clubs, which we have done together, he has done MS program in pediatric surgery in AIMS. Deepak, would you like to make your comments? Because I'm very fascinated by the learning as a clinical doctor in clinical medicine, not only in that but also as a researcher in public health, as clearly shown by JSS itself, and Anurag Bhargav, who has been inspired from JSS, has continued later on. So, Deepak, would you have any comment about it, about your experience?
So, good evening, everyone. So, when I came to JSS as a postgraduate resident, I was like, I mean, saw all those things, videos, and there were many journal papers, everything I saw, and everyone was like, my colleagues were preparing for postgraduate, and I was sitting with those journals and videos and was looking for those like 6 to 8 hours. I was totally mesmerized. Like these kind of things are happening in my country, and we are not even aware, even in our textbooks of community medicine. This is really something. I mean, I was surprised, and when I find out, there was a time of COVID, and I alone came to the JSS like 2,000 kilometer, and I was getting post graduation just like 4 kilometer away from my home. And then my father said, like, what is in your mind? I like, this place has definitely something which, I mean, can change my ways of thinking. And then whatever happened is, I mean, I feel really grateful that I had interaction with such a, I would say these are like great people, great teacher, and great mentors, and I really am blessed.
So, how about
let's try and answer a few questions now that have come onto the chat box. Raman, do you mind taking a few of those? So, Akila Ravikumar says, how easy or difficult was it to break the faith of the people in nature, cure, and superstitions, etc.?
So I strongly believe that, the people had no choice until now, until the time that we came. And therefore, whatever they did, we all want to do something which will satisfy at least satisfy us mentally, that we have done the best that was possible. So whether it is faith, whether it is superstition, whatever you may call it, that was all that was available to them. There was nothing better that they had seen. Even whatever government facilities or other private facilities that were available to them, they were either too expensive for them, or they were too poor quality that it would make any difference to their health status. So I think that was a sort of fait accompli for them. And once they started seeing that good quality care is possible, that it is possible to get back well even when you are in a dire situation, then the faith gradually built up. It was not something which happened over 1 or 2 years, but it was by word of mouth, and it developed over a period of probably 10 years or so.
There's another question by Venkatesh Natarajan, who would like to know more about the setting up of the labs and challenges in quality control. How is the attrition and manpower being managed? So there are 4 questions there for you. Setting up labs, challenges in quality control, those are 2, and attrition and manpower being managed.
So we were very fortunate to have Dr. Bishwaroop Chatterjee as one of the founding members. He was a microbiologist, but he was extremely well-read and also extremely knowledgeable about what it took to establish a lab, especially because he had worked with his father, who was a leprologist in a small place in Purulia. So he really had the knack of doing simple things which could make a huge impact in patient management. So those simple things, whether it was microscopy, those skills is what he transmitted to the initial batch of lab technicians. And I think the initial batch of lab technicians that he has trained were amazing. They, in fact, are there with us even today. 25 years on, the same people are there with us today. So there hasn't been any attrition amongst those people whom he trained. And So they have been able to carry this baton forward, and they have trained under them. They have trained other lab technicians. Getting qualified lab technicians was not a problem because they were there as dime a dozen. But those qualifications actually meant nothing because they had never seen anything, never done anything with their own hands. So they had to be sort of trained from the very beginning. And once they were trained, there was, they really felt that, they were doing useful work, and they decided to stay on. Many of them have decided to stay on. So we have almost 8-10 people who are more than 15 years in the laboratory with us. And we have also recently started the pathology technician course, which is a certificate course of the government, a paramedical technician course of the government for tribal youth in the same area.
Raman, another question. How do you, so this is from Tara, how did you all manage regarding your children's education?
So I think Madhvi would be in a better position to say it. But
Madhvi, would you like to? You'll need to unmute, please. Madhvi, you're muted.
Maybe while Madhvi is thinking of a question, how to reply that,
No,
or
I think
unmute.
she's.
Having some technical issues here with the audio.
Okay. She can come to your computer. You come to your computer.
So one of the reasons I'll just continue here. So
Is she audible?
Am I audible now?
Yeah.
Audible?
Yes.
Yeah, yes, you're audible.
So yes, education for children, when we were there till 2009, and kids were in primary school at that time. We stayed in Bilaspur so that children could go to the schools, and we commuted. And I remember all the men contributing in the night duties. So it was division of labor, Raman, if I'm answering the question appropriately. But of course, after that, when we left in 2009, I'm sure Raman, Yogesh had more challenges when kids were in 10th and 12th. So I acknowledge that challenge I did not face, but I can see that children do learn from what their parents are doing, and I can say that our children's lives have been shaped by what they saw as kids, because they often came to the campus and we were, staying very close by. So education means even that. So what they saw was the education apart from the schooling.
Thank you, Madhvi. Ajay, you wanted to say something.
Yes, sir. One question actually goes to Dr. Anurag Bhargav. He can reply it much better than anyone else, and also maybe Yogesh Jain. About the diabetes in underweight people there, which is a significant issue there. And at one time, in one of the comments, Anurag Bhargav says that could it not have been classified as another type, like type 5 diabetes? Would you make some comment on that, something for us to look?
So I think the whole issue, as I was telling you, that there is a disconnect between medical education as well as research in our country into problems of rural people. And what Raman referred to is we don't really understand, our own public health problems. Hypertension in a rural area has a different probably pathway as well as diabetes also. So what we actually realized was that undernutrition was playing a part in both. And research in the West has shown that when you are exposed to undernutrition in your fetal life, in your intrauterine life, you already are born at a disadvantage, which will make you survive that pregnancy, but you have a higher chance of having hypertension and diabetes later on. So this thing we actually saw being played out in front of our eyes. People who are short, people who have diabetes, because they have been chronically undernourished starting from intrauterine this thing. So, but yes, all these things are of immense importance. We have chronic kidney disease now in various parts of India where the etiology is not clear, and this has been noticed again for a number of years. So I think the issues of, we should not assume that diabetes in India is driven by the same factors or kidney disease has the same factors, but we need to work on our problems. And for this, the primary care practitioners have to be involved in the research with the tertiary care institutions so that the problems that we see are worked on with, and the resources are there in tertiary care. We could not do any research of that kind in Ganyari, but somebody can. So, yeah. So the partnership and collaboration.
Wonderful. We have got Dr. Saibal Jana as well there. Saibal Jana has been like a guru. He's a guru for all of us, certainly for almost everyone in JS. An incomplete meeting without comments and suggestions and his sharing of his experience. Dr. Jana, sir? Dr. Saibal Jana? Or while Dr. Saibal Jana is preparing to reply, maybe we could have comment from Shiv Singh about training opportunities, because Shiv Singh and myself, we often talk about it, how we can really help establish highest quality skill development center there. Shiv, do you want to share some views on this?
Hi, hi Ajay, and hi to Raman and Yogesh. When I first went to JSS, for me it was like a pilgrimage. I still call it a pilgrimage for me. I mean, it's an eye opener for everyone. I mean, the kind of humility, the kind of dedication people have there is just out of the world, and I don't think you can get that kind of experience anywhere. Now there have been issues with I think finances and things, and I have actually put in the details. If somebody wants to contribute from India or from abroad, they can actually do that. So please do that. We want to use this center as a center of excellence for training. So we have done recently, we were there and we conducted the courses there. Maybe in the future, we would actually make it a center for training in the critical care as well as in anesthesia and regional anesthesia. And this will actually open up opportunities because we will not only be able to provide anesthesia services, but at the same time able to train people in surgical critical care, medical critical care, and part of anesthesia. We would obviously be charging for that. I mean, I have discussed few of the things where people can come and experience. I mean, even if you are not coming to work, for a very, everything is provided there, accommodation and your, food and everything is provided at a very reasonable rate. And I think by contribution, you can come and actually spend some time and see what amazing work is being done in JSS. I think for me, like I said, every time I visit, I feel that I don't actually have to go to a temple.
Dr. Saibal Jana, sir, are you there? If you can make some comments. And
Anurag said Dr. Sunil Kaul is on the.
Oh yeah, Dr. Sunil Kaul.
Dr.
Yeah.
Kaul, could we have?
Yeah, Dr. Sunil Kaul, sir.
Words?
Yeah.
Oh, hi. No, I don't think I should be contributing here. I think JSS has been, as somebody said, it's a pilgrimage for many of us. And I've been following this since whenever they started and before that as well. I really feel that any one of us, I think, who's called upon to just help out in any which way. I think I've only done that. I think they've been doing the hard work, and I still wish that my role now is to see that to see that this work continues beyond them. And I just hope that all of them who founded it come together again and see it to its logical conclusion as a fine institution. As many of you have kind of said also that it's a dream for many of us in the medical this thing. I wish I could have joined them. I had decided to work in the Northeast and probably never joined them. But otherwise, this is a fine place to be in and live your dream on a daily basis. That's all I want to say. Thank you so much.
Anurag Mishra, do you want to share your experience? Because I know you come very often there. And Dr.
Yeah,
Saibal.
Yes,
Sir. Yes, sir.
actually,
Dr. Jana is there.
Yes, sir, Dr. Jana, sir.
Yes. Actually, before starting the JSS, actually, there Dr. Satyamala, she was the frequent visitors of Sahyog Hospital, and because the Binayak also was with us to work here, and actually, and then the young fellows like Yogesh and later on Raman also came here and worked here for some time. So actually, they have decided to start some work on what to do. That time we actually met with our collector was there, Harshbandar was here, and we requested Harshbandar to give some place to work them actually, and they have started the work. That's a very interesting thing is that some of the things is very interesting. That if you see the real picture of the malaria in Chhattisgarh, the role of JSS is very important because the also role of Jogesh Jain, which I don't know he's here or not, and also the laboratory technician like the laboratory in charge, our Vishwarup and also the technicians also. They helped us, and to not only us, they helped Chhattisgarh government to combat the malaria. This is a very interesting thing that they had done. Other things is that the primary health care and the secondary health care, that is and the public health, that is the tremendous work uh, they are doing. I think it is very interesting that that 25 years they are doing the work, and this is very good. I think they will continue their work for all long time. I think so. Okay.
Dr. Usha, you have your camera on. Did you want to say something? Please unmute yourself. Dr. Usha, you're muted.
Usha, we can't hear you. You're still not unmuted. You're still muted.
Yes, hello. Wonderful, Raman, seeing you after so long. Saurabh is also here.
Hi.
And Saurabh remembers his visit to the organization. And he has told me in all detail whatever he saw. And we met Yogesh some time back. And one thing very interesting I want to share about Raman and Yogesh is that even during undergraduation, they were different than most of the people. And Yogesh had started something called Chetan, which I used to accompany them to the slums near Masjid Mode. And then there was one rational therapeutics. So we used to have discussions about what are rational therapeutics. So what we see of Raman and Yogesh right now, the seeds were already planted long before I think they entered MBBS and was reinforced during their MBBS days. So it's amazing to see the whole team work so well. And my regards to all of you and thanks so much. I'll just give it to Saurabh.
I have nothing more to add than what Usha has already said. One of the other things which people asked about children's education and so on. What do you do about your say complex medical illnesses that you may yourself have? How do you seek sort of advanced medical care just in case it's required?
So I mean, we are now in the 60, so entered 60, and fortunately our peers are still there at AIMS and some of the other institutions. So, but we don't know what will happen once they retire.
No, I'm sure there will be sufficient generations who know about you, so I don't think that's going to be an issue.
Maybe I'd say a few words about my experiences at JSS. From 2010 through till 19, my wife and I used to spend our vacation at JSS. When we initially started visiting GSS, they had a huge clinical workload and they were always short of hands. Over the years, they've gradually had an improvement in this clinical skill set that they had available. They also had an increase in the number of people who could contribute to. So the first few years, my wife and I used to sit in the outpatients and brush up our. So I'm a surgeon. My wife is an anesthetist. We brush up our medicine while sitting in the outpatient, seeing all kinds of patients. But in the subsequent years, I think I spent much more time sitting with them, thinking about ways and means to try and get various things happening at JSS. Unfortunately, a lot of the projects that we thought of didn't materialize. We tried very actively. I think Yogesh, Raman were very keen on it. We very actively tried having a strong collaboration between an official institutional collaboration between the All India Institute in Delhi and JSS, but unfortunately that didn't happen. This was despite a lot of people supporting the idea, but for various reasons that didn't happen. JSS is a unique place. There are many more rural centers doing fantastic work. I'm not trying to belittle the work that they do, but I think JSS has a very unique place, which it is created within the healthcare service providers in rural marginalized populations. The kind of work that they've done can only be experienced. What Raman has said, you can't understand the enormity of the work unless you actually visit JSS. And for those who say it's they don't need to visit a temple, I think I've been to heaven. I don't need to go anywhere else. Thanks, Raman and Yogesh and the whole team for those fantastic experiences that I had, for the fantastic learning that I had in the years that we've been there. We haven't been going there for a number of reasons, but I and my wife have been talking about this, and we hopefully should be able to visit you in the coming years. That's all that I wanted to say. If there are more questions on the chat box, we can try and answer those. There are comments that people have. We could be.
Akila has a question: what language is spoken there? If non-Hindi speaking doctors want to work, could a translator be available until the doctor learns language?
So I think language is not a barrier at all.
No problem.
One should be able to communicate in whichever way, and there are enough people, the nurses, who are able to understand and convey the thing in Chhattisgarhi to the patient if required. So that's not an issue at all.
I think people from different backgrounds, from India, from abroad, have actually physically visited JSS, worked there for a while, and haven't had a language problem, to the best of my knowledge. So that should never be an issue for anybody.
Yeah, Shiva Pillai, if you're still on the call, would you like to say something?
Yes, fantastic work. I must say, when you see it, it's really amazing. You wish you want to do something like this. I also worked in a rural area, and we started what is called RUDASA, Rural Doctors Association of South Africa, and we tried to bring about changes. Notwithstanding what was the amazing surgery that was done, one of our experience was that some of the things that we needed to do was actually, basic preventative care. For example, while it's nice to show a person with a pot spine and everything like that, the real soldiers who did the work were those who went, doing contact tracing, doing dots where we got direct observation of treatment, where the persons went every day and made sure the person took the TB treatment, and then teaching people about the community about how to prevent malaria. And the most important programs for us was nutritional programs of how we had to teach people how to grow food, and we had to teach them how to grow food that once you plant one harvest forever. Planting things like bambara beans, amaranth, and things like that, which was highly nutritious, but very, very cost effective to plant and to grow without much effort. I would have loved some of those programs to come up. I'm sure they are doing it in JSS there. Everybody gets happy when they see some major surgery done. But I wanted to say that those kind of programs, they make a bigger impact because the major things take place with an individual, but just changes society and communities. But lastly, you need a special type of doctor. You need a doctor who is all rounder. You need an anesthetist, a surgeon, and a physician all rolled in one. And I'm not sure where we are super specializing these days, that we are producing that type of a doctor, and whether the ability to do that. And Vidya, I wanted to say there was a challenge to you about training anesthetists to go to rural areas there also. Maybe we must take up the challenge. But fantastic work. I just wanted, I was going to type now to say, if you can just give us a swift transfer details for overseas contributions, we would see what we can do from here. Thank you very much. But Vidya, very, very inspiring. You feel this is what a doctor's work should be, and it's really something to watch it happen. I wish we could set up something like that here. It's a dream, but we always dream, but maybe it'll happen sometime. Thank you.
Priyansh had a question. Traveling back to your initial days, maybe in your 30s, were these assumptions held early on about how systemic change happens that the field realities most strongly challenged? Priyansh, I'm not sure exactly what you meant by that question, but Dr. Raman, if you will take a shot at that.
Yes. So I think we were aware that there would be, these structural problems, so to say, I mean the structural barriers which are contributing to ill health. But they would be to this extent. I was not aware. We were not aware fully. We tried to dabble with some bit of agriculture because that was the major source of livelihood for people. But obviously, we were also immersed in clinical work and in the building of the community health program. So we had little time for agriculture work, but still we tried to do as much as we could. And gradually, we have tried to increase this involvement in the non-clinical but important the social livelihood and social work that we have been doing. I think one sector which we have missed and not been able to do is education, which is also extremely important. So we wish that somebody with the skills and the zeal to do this work here in this area on education could come and take up this challenge. Thank you.
Dr. Vidya, I think we are reaching the kind of past
Dr.
our time.
Anurag has just lifted his hand. So, Dr. Anurag, can you please unmute yourself?
No, I just have one thought, and we as doctors always feel that, we have a certain conception of politics as something that we can stay away from. But in rural areas, you realize that ultimately it's all, the access to resources and the distribution. And in a state like Chhattisgarh, which has only, a 3 crore, this thing, in one of the richest states of, in terms of natural resources, the systemic change that we would like to see is more power devolved to the lower levels of governance. And in Kerala, this has happened and it has been transformative. So over a long period of time, all that we saw in JSS are signals that something needs to be corrected at the bottom level. And in a sense, really, that the tribal communities are some of the best to work with on a long-term basis. But there is an inequality in access to resources. And of course, all these areas are also now facing challenges of displacement. So that is a political issue that actually needs to be resolved. And once that is done, and once incomes rise with proper land distribution or income, then we will see a transformation happening. But in the interim period, what the work of JSS is doing is extremely valuable and important. So that's all.
I have Dr. Sanjay Nagral, who's also been associated with JSS. Dr. Sanjay, would you like to say something?
Oh, no, no, not. Can you hear me?
Yes, yes.
Oh, no, no. So, first of all, I cannot have any claim of being associated with JSS. I have once spent a week there, but and I know, of course, all of them well. So, no, I'm not associated, but of course, I've seen their work. I have uh, sort of referred people, some of our young surgeons, to go and spend some time there. I just couldn't resist the temptation of making one quick comment, which is that in these some of these discussions we make this division between urban and rural health, which is largely true. But I must say this, that even in urban India, the poor, especially those who live in slums and etc., get very different, very low quality health. And so, for those of us who work in the cities, we must be aware of that. That by serving them in whatever way is possible, we are actually also serving people who have very poor access. In city of Mumbai, you will be surprised that the health of people living in the slums is so much different and under so much challenge. So I'm just saying that whilst we must all travel to see the work done by JSS and many other organizations, sometimes it is all around us also, the inequity.
Radhakrishna, would you like to come in now?
Yeah, on a day of colossal tragedy in Ahmedabad, with not just the passengers, some of the medical students dying, unfortunately, this is some sort of heartwarming lecture, I should say, and I'm really amazed to see the sort of work that is being done. And I wonder how such organizations they do not exist in every corner of the country. I think they should multiply and more should be there. Having said that, I have certain concerns and questions. We may sound a wee bit silly, but I just want to know that you're working in a Maoist infested area where Maoists very easily take doctors to ransom. And how the safety, security of a medical personnel and paramedics is taken care of to start with?
First of all, I mean, the area that we work in, we are in Bilaspur, and the extremism that is seen in Chhattisgarh, unfortunately, is sort of being labeled as extremist infested. But actually, there are only very few pockets of extremism, and most of them are in the southern part of Chhattisgarh, or areas which are adjoining Andhra Pradesh and Maharashtra, so close to the border. So that is where most of this extremism thrives. The rest of the places are quite safe, probably much safer than Delhi, I'm sure. Yeah, so.
My second question will be like how do you avoid or keep religious people at bay? Because if these rural areas, some religious groups will come and try to influence patients and do all sorts of things. And you have any issue there?
So we have tried to keep religion completely out of the work that we do, and we have also tried to keep at least the political party politics out of the work. So this has probably held us in good stead until now, and I think that is something that we have consciously done over these last 25 years.
How do you avoid politicians and their goons coming and taking credit on Independence Day and Republic Day and claiming that they are doing something? They'll put up their posters. You have the power to sort of prevent that, avoid that.
So we are not looking for any gains from them. So I think it's mutual. So if one is looking for some gains from them, then it is something that might happen. But we are not looking at any gains from them.
So they don't interfere. They don't come and don't claim the good work and some credit for the work that's done there.
Initially, yes, there were some initial incidents, but I think subsequently people also realize where is the line and what they can do.
What about the doctors' salaries? Are they in par within the cities and your quarters stay? How is it? I mean, how can doctors coming from elsewhere survive there? And how have you been survived?
So, I mean, one is that being in a voluntary sector, we don't like to call ourselves NGOs, but in the voluntary sector, we feel that there has to be a significant component of volunteerism in the work that we do. So we really should want to do it from our hearts, and so money only as much as is required to survive reasonably well should be enough, and that has been enough for most of us. And I think we have tried to now increase the salaries because we have expanded our work in such a way that we require certain people with certain skills and educational qualifications to be there. So we have tried to improve the salary structures, but still, if one were to compare it with government salaries of the same level, then it would be somewhere close to 65 to 70% of the government salaries for doctors as well as for nurses.
Then one last question,
But if
sir.
I might butt in here. Raman is being very modest. I still remember the second year that I was there. There was a strong debate on whether they should increase the amount that they took, and the amount that was being taken by the doctors there at that time was a pittance in comparison to what people elsewhere would get. Nowhere comparable to the private sector, and much, 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 much lower than what the government sector gives you by way of money and by way of privileges. So I think there's a huge component of volunteerism. Raman is underplaying what he's saying at the moment. Sorry to butt in.
One last question, sir. What is the hierarchy? Will there not, because so many big shots working there, no clash of egos, and who lays down the rules and who follows?
So we have from the very beginning we had this executive committee, which is somewhat like the governing board of any organization. So most decisions were taken in a democratic manner, and with discussions and detailed discussions. In fact, we went into prolonged discussions, often delaying decisions at times. But I think many of those decisions, or even postponing those decisions until we had a unanimity on those decisions. So I think decision making was fairly democratic, and has been this tradition has been there from the very beginning. And in terms of hierarchy, we feel that we are quite non-hierarchical, but at the same time, I cannot completely deny that we are city-born, city-bred people who have come to a rural area. So I mean, that difference between the locals and the people who are coming from the forest villages, that difference is apparent. But we still try to maintain that it is, as far as possible, non-hierarchical.
Thank you, sir. It is so heartening listening to your story. Thank you. Vidya.
We are actually out of time, as Dr. Piyush pointed out. So your closing comments, Ajay.
Well, it's an honor to be asked to make a closing comment. There's no more inspiring place for any doctor to work than JSS is. And not just in providing medical care, but how to really look after these people in the society at primary, secondary, tertiary level uh, regarding their capability to really thrive. For example, by providing their know-how in agriculture produce. So I really find working as and when I get a chance to go to JSS very, very inspiring. Thank you very much.
Your comments, Dr. Piyush.
If there's anybody today in the meeting who hasn't been to JSS, you haven't seen and you haven't felt what Raman has spoken about, please go and visit JSS and make your own opinions about what JSS is. The inspiration that Ajay is talking about will be phenomenal. It's something uncomparable. You can't imagine it. Just go there. Thank you.
So Radhakrishna, we have to plan a trip quickly. Your closing comments, Dr. Kataria.
I just want to thank everybody for their time. It's been more than 1.5 hours, I think 1 hour 40 minutes since we started. Thank you so much for all this time and your attention here. Thanks once again. Thank you.
Thank you so much for joining us despite your busy schedule. And I got, hint from some people that you are not usually so forthcoming. So thank you so much for agreeing to come on Marvelous Medicine. And thank you, Ajay, for bringing him, and Shiv for doing a lot of background work to make sure that, we have a lot of people logged in to listen. And we'll be putting up the recordings later. So hopefully more people will get inspired, and we're looking forward to meeting you in person there.
Thank you. Thank you, sir.
Thank you. Bye, Raman. Thank
Bye.
you.
Bye.
We'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe.
Thank you. Thank you.